Dr. Ramakrishna, YouTube link भेज. Okay, got it.
डन सर।
Okay.
रिकॉर्डिंग शुरू करना।
Only 12 people joined. We will wait for another 2 minutes, then start.
Caramba, mungkin.
Latest projection.
Siap. என்னென்ன கூட அடிச்சிருக்காங்களாமா?
चक्कर क्यों आ रही
Madam, can we start? Doctor, Dr. Soumya, we can start. You can introduce yourself. then Dr. Hinal, then you can start.
Yeah. Good evening, everyone. Myself, Dr. Soumya Singh, and I'm currently working as an assistant professor in SGPGIMS. And welcome, Dr. Hinal, for today's session.
Good evening, ma'am. Uh, I'm Dr. Hinal, third year DNB resident at Pune Hospital and Research Center. I'm going to present case presentation on hyperkinetic movement disorder. Shall I start, ma'am?
Yeah, please start, Dr. Hinal.
Yes. 28-year-old female, resident of Baramati, studied till 10th standard, housewife, right-handed, informant father. She came with chief complaints of 4 years history of behavioral changes. Since 2 years, there is abnormal movement of mouth, 1.5 years history of seizure, and 1 year history of unsteadiness while walking. So, a history of present illness. Uh, she 28-year-old female born of non-consanguineous marriage was doing all her housework work till 4 years ago. Then she since 4 years she started having behavior abnormalities like feeling anxiety and fearfulness that something bad is going to happen. Always she used to tell her family members that she's feeling a low mood and fearful, and she was not feeling like doing anything. She started doing household work very hasty. After few months, she started doing her household work very hastily, but she used to cook without any mistake. These symptoms were fluctuating and they were not progressive, and there was no memory impairment or any other change in or any other change in behavior. So after 2 years of this symptom, she started having normal movement of the mouth. At that time, she was 7 months pregnant, and those normal movement of the mouth were like intermittent, non-sustained, repetitive, movement of puckering of lips, movement of the jaw to one side, flaring of the nose, and crying like face. These were insidious in onset, and they were present at rest and also while talking. Could not voluntarily suppress this movement, and they stopped during sleep. There was no history of temporary stoppage with any action, and no other movement was associated with this uh, uh, nearly movement. And she was able to eat and swallow, and speech was normal at that time.
Okay. So, Dr.
She,
Hinal, go back to your
yes,
slide,
ma'am.
please. The first slide.
Yes, ma'am.
First slide. Okay. So, in patient of neurology, among demographic status, what else you will be telling? So, along with the
Reliability.
handedness, yes, along with the
Mm.
handedness, you have to tell what language patient can speak and write. Okay,
Okay.
so how many
Yes.
languages patient can comfortably speak and write, that has to be told, and the informant is reliable or not.
Yes, ma'am.
Okay, now can I
Okay,
come
ma'am.
to next slide, please?
Yes, ma'am.
So in this, when we tell the chief complaint, so was this patient having seizure for last 1.5 years, or was there any one or two episodes only?
No, ma'am. Only initially she had one episode, and then after a year, 2 to 3 episodes were there. They were not continuous, ma'am. So I
Okay,
was
fine.
also
Please come. Okay, please come to next slide.
okay. So, ma'am, when such history is there, should we
No,
mention like
yeah, definitely it should be mentioned. And if there are 3, 4 episodes over the last 1.5 years, then definitely it should be written like this only.
okay,
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 come
ma'am.
to next slide, please. Okay, no, analyze your history.
Uh, so 4 years ago, she was completely all right, and then she started having anxiety and fearful, like behavioral changes were there,
So,
but they were
whenever we are describing these behavioral changes, so in case of whenever there is cognitive changes in any patient, you have to tell the baseline cognitive and functional status before starting history.
yes.
So,
So
among your
yes.
domains, yeah, please tell.
Yeah, so 4 years ago, she was completely all right. Like she used to wake up, do her all household work. Her cooking was she used to cook properly. There were no mistakes like cooking or doing any other household work like cleaning and housekeeping. And she used to maintain like her sleep was normal, and she used to go out to buy vegetables. So it was all normal, ma'am.
Okay. So among that household activities, we have to tell regarding hygiene of personal as well as a very personal space. Then her
Okay.
executive functions, in which you can describe her cooking or her any that planned activity that she was doing at home. Then whether she was doing any shopping or not, how was she among the calculation? Okay. Then what was her religiosity? What
What
was her
was her,
behavior?
ma'am?
Religiosity. Religiosity is very important. When you take a history of religiosity or doing a puja, you will get an excellent execution. Sometimes the patient will be missing the steps. Sometimes they'll be just continuously doing the arti and they won't be stopping until and unless someone asks them to stop. So, like cooking, you can take the history of this execution and perseveration and a lot of frontal dysfunction during their religious activities. Okay.
Okay.
So that is very important. Sometimes when the behavior changes, they become over religious. Sometimes they just stop doing completely. They just stop doing their puja or those things. So this thing is also important. And then their behavior with the family members as well as the neighbors. If she was involved or if the person is working, then how the behavior changed among the peer group and among the seniors or juniors. So this much history in a short thing you have to tell before starting the cognitive domain, the history
Okay.
of a cognitive decline that you are telling. Okay, now the first complaint.
Mm. No, abnormal
So
movement or anxiety,
the
ma'am.
the first thing you told that the patient was having fear that something bad is going to happen. So what is this?
Ma'am, fearfulness, anxiety only be, ma'am, mostly because she
No,
was not
what
telling
was
what.
this?
Yes, ma'am.
Okay, so there is a thing which is called a delusion of paranoia. Okay, so
Okay.
we have to ask the family that whether this fear persisted in spite of giving a valid reason against that. Or so this should be asked. I mean, whether this
Okay.
along with the fear, whether there was any suspiciousness as well, whether she was feeling that someone is also threatening her, or something bad is going to happen to her family members or kids, or to whatever family members are there or some people are trying to invade her property. So all the details should be taken.
Okay.
Okay.
There was no
So
paranoia, ma'am. Only she was just telling the relatives that I am feeling fear. I'm not feeling good like that. There was no
no,
like
so when the family member tried to console, did she got consoled? Whether her
for
this
some
belief
time.
of that fearfulness persisted.
No, ma'am. For some time she used to be all right, and then again she used to tell the same thing. But no, nothing like someone is going to harm the relatives or herself.
So what is this definition of delusion?
This is a false belief that uh,
If
that something which is not true is happening.
no, so it's a false, firm, fixed belief over a thought in which even if an evidence is given against that, the person continues to believe so.
Okay.
So that is a delusion. So most likely your patient, if the family members were trying to console and giving evidence that there is nothing going bad is going to happen, if she was still fearful, that means your patient was developing delusion. Okay.
Okay.
Can you tell me how many types of delusions do we commonly encounter?
Uh, Paranoid delusion. Uh,
Okay. Yeah.
um, then grandiosity, then
Okay.
persecutory,
Okay.
then mm,
Delusion of misidentification, delusion of reference, and erotomania. Okay.
erotomania. Yes, ma'am.
Yeah. Come to the next complaint. Third line.
Uh, she was having low mood and was not feeling like doing anything.
What is it?
Mainly depression, ma'am.
It's depression or apathy.
Hmm. Apathy. Apathy is. uh,
So
But
in
she was
depression,
doing when she was, when her family members used to tell her, like she was able to cook during that time, ma'am. So
also a depressed person can also cook, apathic can also cook. So that is not a thing. See, in depression, what will happen? Along with a low mood, the person will not be having pleasure in activities that they used to have in previously in those things. Okay, what is her appetite during that time? Was there any sleep disturbances as well? Or there was just a lack of initiation only. So but it's just a lack of initiation and not having interest in doing activities and without any inner feeling of that guilt or the low mood, then that is apathy. While the person is not feeling like doing anything, it can be anything. So that should also be liberated. Okay.
okay.
Okay. Come to the next thing.
Uh, she started doing her household work very hastily, but according to her father and mother, she used to cook without any mistake.
What does it mean? I mean, what do you want to say? But did our speed increase actually during that time, or what is this thing?
Uh, Speed only, like she not exactly speed, but she uh, wanted to do everything very fast. Like patience was less. Like
Okay. 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 Fine. And it was fluctuating. Fluctuating what? Fluctuating within a day, fluctuating over days. And why does
over
it
days,
important?
she was fine in between, and then again, uh,
For
this
few
used
days
to
she will
occur.
be fine, and for few days she will again start having these complaints. So why
Yeah.
this fluctuation? It is important to ask, and why it is important to dictate that whether it is a fluctuation within a day or fluctuation over days. In which disease or in which conditions you see the fluctuations in symptoms or the cognitive change within a day?
Lewy body dementia,
It's a delirium. When
ma'am.
there is a fluctuation, yeah. Hi, am I audible, Meena? Dr. Meena, am I audible?
Yes, ma'am.
Yeah. So when the fluctuation is within a day, when the cognitive changes are there within a day, the patient is fluctuating, then it is what it is. We are dealing with delirious patient. The delirious
Okay.
patient, if you see in your ward, for some time they will be normal, they will be giving you appropriate answers, they'll be telling you everything. And after 2, 3 hours you go, you see that these patients have got an altered sensory. Okay. Versus the fluctuation over days is a feature of dementia with Lewy body.
Okay.
So that's why it's important. Okay. Okay. Next complaint. There is no memory impairment or any other change in behavior. So where do we localize these behavioral issues? And psychiatric issues word should not be used. I mean, dementia, this is just a behavioral complaint. These are behavioral issues, not psychiatric issues. We won't be labeled these patients as psychiatric.
No behavioral issues.
Hmm. So what is localization? What do you think? Where is problem?
And prefrontal
Prefrontal cortex is very big. Where in prefrontal?
orbitofrontal
Along with it?
and medial frontal also, because the initiation she was not
Yes.
feeling like doing
So it is,
anything.
yes. So in medial frontal as well
Motivation
as
was,
orbitofrontal, yes,
yes,
motivation is less. Probably your patient is also having some kind of apathy as well. Okay.
yes, ma'am.
So along with the anxiety, was she having aggressiveness? Was she shouting excessively to people around her
No,
or fighting
no,
with
ma'am,
family members?
not
Nothing
initially.
was there. Okay. Was it there later on?
Yes, ma'am. Irritability and aggression was there later, but not shouting or hitting people.
Okay. Okay. Come to your next complaint.
Yes, ma'am. So after 2 years,
Were
huh?
one more thing. Were these complaints making any interference in our daily activities
No,
or in
she
our
was able
daily?
to do, but only she was the motivation and initiation was a little problem. Otherwise, she was doing her
She was doing normal.
all
So,
instrumental areas
okay,
also normal.
okay, okay. Come to next one.
So after 2 years, during her seventh month of pregnancy, she started having abnormal movements of mouth, which were intermittent, non-sustained, repetitive and puckering of lips, movement of jaw to one side, flaring of nose, and crying like face. They were present at rest as well as while talking, and they could not be voluntarily suppressed. She could not voluntarily suppress these movements, and they stopped during sleep. And there was no history of temporary stoppage with any action, or no other movement of limbs was there, and she was able to speak and eat normally.
Yeah, sorry. What
So,
was that? Yeah,
analyze, ma'am.
yeah. Analysis. What is happening?
Ma'am, there was mostly dystonia because oromandibular dystonia because it were non-sustained and intermittent and pattern movement was there. So and it used to they were non-suppressible and they used to stop during sleep. So and no other movement. So only oromandibular dystonia at that time was there.
Okay. And this was
And
during
no,
ANC status.
yes, ma'am.
This was during ANC status,
Yes, ma'am. Seventh month.
7 months of ANC. So what comes to the mind? First thing.
Uh, uh, Chorea gravidarum comes to mind, but then it occurs in the first trimester, and
Yes.
these seem like more dystonic movement than
More.
coriform.
Yes,
So,
exactly. Other than that,
and they were not relieved also even after the delivery. And this is seventh month. Usually, the Chorea gravidarum occurs in the first trimester.
first trimester. Exactly. Okay. Go ahead with the next slide.
Yes, ma'am. So she delivered after 2 months, followed by which 4 days later she had episode of irrelevant talk and excessive talking. Showed to a psychiatrist for the same, and she was started on some medications. And after 10 to 15 days, she had a tonic-clonic posturing with uprolling of eyes and frothing from mouth at the clinic itself. And there was no tongue bite or urinary incontinence at that time, and she was started on medications for the seizure. Um, uh, Also, after a few days, she started having a mild upward movement of the trunk while sitting, which was brief, intermittent. It was not regularly occurring, jerky, and it was present at rest as well as on action. It was non-suppressible and it used to stop during sleep. After thereafter, the after 1 year, she started having unsteadiness while walking. The pace of her walk was normal, but she was while walking, she was swaying to either side, and she could not stop walk straight. But there was no broad-based gait, and she was bending. A little bending was there to one side while walking, and there were no falls at that time. Slowly, the disease progressed such that she started becoming irritable, aggressive, and even she stopped doing her household activities.
Okay.
Progression over
Analyze.
last six.
w-
Yes, ma'am.
Wait. Go back to your slide. Go back to your slide. Yeah. Analyze the symptom. No, no, no. That slide. Yeah.
Uh, Ma'am, after the delivery,
Mm.
4 days later, she was having irrelevant talk and excessive talking, maybe psychosis or mm, hypomania. So she was started on treatment, and after a few days, the symptoms decreased with the treatment. And but after later during the clinic only when she was showing to the psychiatrist, then the clinic only she had GTCS.
Okay. So, what is classification of seizure? New classification of seizure. Can you tell me?
Yes, focal, generalized, and unknown. In focal, it is focal with impaired awareness and preserved awareness, and with motor symptoms and non-motor symptoms. Again, generalized same with motor and non-motor symptoms, and unknown also motor and non-motor symptoms. Also in focal, there is focal to generalized.
Okay, so there is a new classification that has been given 2 months back by ILE. So go through that. Okay. So it is not a focal onset. Now the word of onset has been removed. It is a focal only. Okay. And
Yes, ma'am.
awareness has been replaced by the consciousness.
Consciously. Yes, ma'am.
Okay. And among and under the consciousness, there has been few words like awareness and other words. Other than
Ye-
that, your patient had a seizure in the clinic only. So that means there must be some observer who has seen this.
A
So
family
you have to
member.
be
Yes,
family
ma'am.
member. So was it seen by some physician as well, or only the family member has seen?
No, ma'am. The family member only. But after the episode, the doctor had seen.
Okay. So whenever you are describing a seizure, it should be detailed. The first thing, from which part it started, not the tonic-clonic posturing. Tonic-clonic posturing of what? Of a one limb, all four limbs.
All
What
four
was
limbs were.
happening? So
All
whether
four
it
limbs.
started from all the four limbs at one point of time, or whether it started from the head, or whether it started with the uprolling of eyeballs, one thing. And whether there was any ictal cry or not. Was the patient have any premonition or aura before the seizure? What was the duration of seizure? After that, was there any post-ictal confusion or not? Whether she sustained any injury during that period of seizure or not? So all these things has to be described in detail.
Yes.
Okay, so history of seizure, you should have what kind of seizure patient was having. Was there any focality? Try to get any focality because your patient had not only one episode of seizure. Your patient had 3 to 4 episodes. She also had seizures afterward also, no? So you have to
After
try
this,
to
after
ask.
1 year, she got. After
Yeah, so
6 months
that
or
should
eight.
be told at one place only. You won't be
Okay.
telling this like at one seizure at this time, one seizure you will tell history after 1 year. No, you are describing one complaint, describe it
Okay.
completely over there.
Okay,
Okay,
ma'am.
and try to find out was there any tongue bite only at the sample? Was it over the one side? Always it is getting on one side. Whether patient get any premonition or not? Was there any aura-like symptoms? So that should be told.
Okay, ma'am.
Okay, and
Yes, ma'am.
other than that, before having seizure, was she encountering any febrile illness during that period or not?
Okay, ma'am.
So that should also be kept in mind. So all those things has to be told. Now
Yes.
come to your next thing.
Uh,
This
she started having mild upward movement of the trunk while sitting, which was brief, intermittent, not regularly occurring, jerky, and at rest and action, but not suppressible, and it used to stop in sleep. So
so
most
what is she experiencing?
uh, truncal chorea, maybe because it was jerky and it was not regular or patterned. It used to occur like non-regularly, and it was very brief, just a sudden upward movement.
Korea is not jerky. The jerky word is used only for the myoclonus. Okay.
Myoclonus, but
Yeah.
this
So
was not regular, ma'am. It was um,
so the word jerky should not be used when you are
okay,
describing Korea.
okay,
Okay.
ma'am.
And well, if so, you are thinking that your patient was having a coriform movement. So initially you described these oromandibular dystonia initially, and then after that your patient was having Bebel complaint and dystonia, and after that she had the seizure, and now she has started developing abnormal coriform like movement.
Yes,
Okay.
ma'am.
Afterward, next.
After 1 year, like last since 1 year, she initially started having unsteadiness while walking. Her walking pace was normal. She was not slow her pace was normal, but she was little swaying to one side while walking, and she was not able to walk straight. She used to go here and there while walking, and mild bending to one side was there during walking. But there were no falls initially. Her gait worsened later.
So what is that? What is that?
Uh, since above, ma'am, the Korea had mild Korea had started, I would think of the truncal Korea only, because of which there was this gait was getting
Why not
affected. But
ataxia? Why not
it
cerebellar
could
ataxia?
it could be cerebral ataxia also. But they said there was no wise gait at that time.
Patient won't describe no the right-based food.
Yes.
So at this point of time, we'll keep our mind open.
Yes,
So
ma'am.
it can be sensory ataxia, it can be cerebellar ataxia, or your patient might be experiencing because of movement disorder. She might be experiencing unsteadiness in gait. So on
Yes.
history basis, how will you differentiate the sensory versus cerebellar versus this movement disorder related gait?
So I'll ask about wash basin sign or slippage of chappals, and was she able to feel the floor,
And
and was it increasing during darkness, and
it's a see all the ataxias worsen in dark, all the ataxia. So the question should be asked that whether there was a disproportionate worsening. So the word of a disproportionate is important. I mean, in nighttime, everyone encounters some difficulty in walking in compared to the daytime. So all the excess will worsen. So the disproportionate worsening is there or not? Okay. And along
okay.
with that, is there any the perception of the fluid, whether it is same or the person feels like something cotton wool like sensation, or the floor of perception has changed to the dirt or mud like thing. Okay. And for the
Yes.
cerebellum, what will you ask?
Uh, Cerebellum, was there incoordination of hands also associated
No,
dysarthria
for the
or
gate. No,
narrow?
no, for gate only. First for the
Uh,
gate only.
on on uneven surfaces, was it increasing, or was her gait little broad based, like she was
So
walking two
the thing
feet apart?
Okay, so the cerebellar ataxia, you have to ask that whether the person was encountering a difficulty in navigating through the narrow passages.
Yes.
Okay, so you have to ask that if there are a narrow passage, does she encounters more difficulty or the difficulty is same, whether it's a narrow or the broad ways.
Hmm.
So that is the thing that you have to ask in the patient of cerebellum. While in case of a movement disorder patient, for example, a patient is having coriform movement or a patient is having foot dystonia. So in that thing, the person will be having a same problem, whether it's a narrow thing or whether it's a the broad ways or the broader areas. Other than that, if you are thinking that a patient is having unsteadiness because of coriform or some movement disorder, you have to ask certain more questions. Was there any diurnal variation? Is it important?
Yes, ma'am. There was no diurnal variation
So
for
that has
dopamine
to be told.
responsive. Yes, ma'am.
Dystonias. So you have to ask whether the dystonia will worsen as soon as the patient will start walking. So whether this worsen at the time of an exaggeration, sorry, at the time of an this exertion, does this does this walking difficulty worsens or not? Okay. And other
Yes,
than
ma'am.
that,
Um, any limb associated limb movement is there, or neck movement is there?
yes, whether there any movement of trunk is there or not. Because most of the people, if you're saying that already the patient was having a movement of trunk. So whether the patient develops a sudden myoclonic jerk and because of that she falls or she encounters a difficulty in walking, so that should also be taken in consideration.
Yes, ma'am.
Okay, so for the gait complaint, it should be complete from the starting. She can stand up from the sitting position or not, whether the person can walk, what kind of gait difficulty they are encountering, what is there, whether they walk like a drunken person or there is just some flinging movement of limb is occurring. Because of that, they are unable to walk. So that should be everything has to be told very discreetly. Okay. Now
Yes.
come to the next complaint.
So slowly her disease progressed, such that she started becoming more irritable and aggressive, and she had stopped doing her household activities. Uh, uh, she had started making mistake in cooking also, but more of her lip movements had started. So then she had stopped her because of that also she had stopped her routine activities, instrumental activities.
Okay. What moment was she having in her life?
So, ma'am, over the last 6 months, there was increased lurching while walking. There were falls due to dashing against the door or other objects. Upper limb abnormal movements were there, like they were very irregular and non-sustained jerky movements uh, present at rest as well as on action. And there was history of dropping of objects from the hand also while holding the object. And initially, she used to these movements suppressed during sleep, but now they are present even during sleep, such that she used to hurt her daughter. A few times she had hurt her daughter by um, movement of her hand, and also there are some associated abnormal movement of legs also while walking. And even now, her speech has become non-comprehensible to the relatives, and there is abnormal movement of tongue also. So while eating and swallowing also has become difficult. She has to push the food inside the mouth, and otherwise the food will come out of the mouth. And also there is lip and tongue bite associated with the these movements. And but she is able to understand spoken words and name uh, things, understand the words, ask for things. And but because of those movements, she's now requiring help while dressing and bathing. But there is no any incontinence, or she's able to navigate within the house.
Okay, so now what is happening?
So now, ma'am, the chorea has increased and it has become generalized, involving the upper limb, lower limb, as well as the gait has become very bizarre, because of which she is dashing against the floor and objects, and she is falling down. And multiple times during a day, the falls are there at present. And also because of her tongue movement, the speech has become non-comprehensible, but her language is comprehension is intact.
Okay,
And self-mutilation
so
is also there, like tongue bite and lip bite.
no, that's a different thing. What is self-mutilation and why do the patient of dystonia and chorea encounters a tongue bite?
Uh, because of this um, movement or abnormal movement of the tongue, or the
So in patients
jaw
of
movement.
yes, in patients of oromandibular dyskinesia or dystonia, the tongue bite is very common. See, there are
Mm,
jaw opening muscles and jaw closure muscles. Okay.
mm.
So what are the muscles in the jaw which are jaw opening and which are the muscles which are responsible for closing?
Ma'am, lateral pterygoid muscle is there for opening.
Mhm.
Uh,
Yes, and
other mylohyoid, genohyoid. The
no, genoid is
closing
not
muscles are
considered.
uh, closing are masseter, temporalis, medial and lateral pterygoid.
No. The lateral pterygoid is jaw opener and temporalis, masseter, and medial pterygoid is jaw closure. Okay.
Yes,
So the
ma'am.
dystonia is what? It's a movement which is occurring in both agonist and antagonist. Or
Huh.
whenever these are involuntary movements are happening, your patient is having what? Your patient is having both. She is having lingual movement as well as there is jaw movement.
Yes, ma'am.
And there is an incoordination among these movements. So because of that, of a recurrent jaw closure at the time when the person is having this tongue movement, they encounter tongue bite. And it's very common. If you encounter a patient of jaw closure dystonia, there is a frequent complaint that while chewing the food or while talking, they encounter a recurrent tongue bite. That is not a self-mutilation. Getting
Okay.
my point?
Uh, because
Yes,
of the
because of the
incoordination of
yes, because of the incoordination of movement, they are experiencing this thing.
yes, ma'am.
So now the patient has developed a generalized chorea. So what is classification of chorea?
Uh, so, ma'am, genetic chorea, structural, and metabolic. We classify based on two things actually. Sorry. First, based on upon age of two axis, age of onset, temporal evolution, onset based acute, subacute, chronic, and whether it is continuous or intermittent, or remitting. And second classification is based upon whether it is genetic or acquired.
Yes.
So based
So
on age, uh, uh, childhood onset is benign hereditary chorea or ataxia telangiectasia or AOA, and adult onset, there will be Huntington's or uh, NBI 17, then DRPLA, then HDL like 1 and 2, um, all those and neuroacanthocytosis, all those genetic causes, and acquired causes will be structural, or it could be because of ischemia, like in infarcts or infects of caudate nucleus or subthalamic, and Sydenham's chorea because of rheumatic fever or chorea gravidarum, and metabolic
Okay.
choreas like
Okay.
um, hypo or hyperthyroid, or hypo or hypernatremia,
Okay.
like, or infective like
So,
HIV.
okay. So till now, can you summarize your case?
Yes, ma'am.
Anything else, or is it? Yeah. Go for your negative history. Yeah. Go for negative
So
history.
there was no history of forgetfulness or navigation inside the house, or identifying object or faces. No limb weakness, no sensory complaints, no vision, facial sense loss or asymmetry or hearing difficulty, no bowel bladder incontinence, no hallucinations or delusions, no history of fever, altered sensorium or weight loss. There is no history of perinatal insult, infection in the childhood or trauma, and there is no history of exposure to drugs or toxin. Um, so current functional status, she walks independently but falls daily, and instrument ADL are impaired, and she needs help. She is now needing help in ADL also, and feeding is difficult. And she's 28, summary, 28-year-old
So
female, insidious non.
one thing. Wait. What is her family history?
Uh, she is born of a non-consanguineous marriage, and there is no history of such disease in any other family members, ma'am.
So actually, we are dealing with a patient who is having behavioral complaint, who is having movement disorder, along with one episode of seizure. Okay. So in
Yes,
such cases, what family history you will take, and you always must make your family tree.
pedigree.
History
Yes,
is
ma'am.
not complete about that. Okay, there is no excuse for that.
Yeah.
So what family history you will ask?
First is consanguinity of marriage. Then,
Yes,
is there any other family members who had such complaints of behavioral or movement disorder? And
and
any family member who died? Uh,
any history of premature death, and
yes, ma'am.
any history of premature death in family,
Premature death,
and
yes, ma'am.
yes, and
And
any history of cardiac illness. Will you ask that?
yes, ma'am. Cardiac illness, cardiomyopathy.
Cardiomyopathy, and for what? Rhythm disturbances.
Yes, ma'am.
Both are important. Your patient might be having a mitochondrial illness. She is having seizures, she is having cognitive decline, now she is having movement disorder. Any history of what other thing? Muscle illness,
Any muscle illness or peripheral neuropathy, or
or
ataxia,
any history of, yes, any history of hearing impairment, visual
hearing,
impairment.
visual, yes, ma'am.
Yeah. Why visual impairment? What diseases?
Uh, ma'am, mitochondrial disease will have visual complaints. Then
And
ataxia telangiectasia. Then ataxia with oculomotor apraxia. Then
NCL, adult onset NCL. Other than that,
हाँ, mhm,
any history of measles in family, a similar complaint, late onset SSP,
late onset SSPs.
similar presentation, postpartum worsening, pre-existing some behavioral complaints, having seizures, now encountering extrapyramidal symptoms. Okay. Other than that,
Mm.
the history of autoimmune illness in family,
Autoimmune is
any
SLE
history
or
of arthritis,
Sjogren's,
lupus, yes, Sjogren's,
APLA.
yes. So similar history you have to ask in your past history as well.
Oh,
So
yes,
past
ma'am.
history in case of a patient who is a female, young female, okay, who has presented to you with a significant history of within 2 years only. For the nearly 2 years, the patient was well kept.
Yes, ma'am.
Or either you have to describe whether the patient was having actually significant delusion or not. Okay. So if a patient is having 2 years history with postpartum worsening, the differential is very broad.
Mm.
So infective etiologies, para-infectious, autoimmune etiology, metabolic etiologies, all the history you have to take. The history of hypo or hyperthyroidism. So for that you have to ask the patient.
Okay.
So that past history and family history both is very important in your case. Any history of recurrent anemia, history of jaundice, history of blood transfusion. The patient can be HIV.
Yeah, yes,
They
ma'am.
also can have seizure. They also can have cognitive decline. They also can have extrapyramidal feature. So any
Mm.
history of lump is there or not, high risk sexual history is there or not. So that has to be told. Okay.
Yes, ma'am. Yes.
For lupus, you have to take your history. So keep your differential open at the time of your history taking. Don't keep them closed.
Yes, ma'am.
All the treatable disorder should be, you should take a careful history. Okay.
Mm. Yes, ma'am.
Mhm. So now summarize your case.
28-year-old female, insidious onset and progressive worsening of behavioral disturbances with mm, oromandibular dystonia initially, which progressed to feeding dystonia and incomprehensible speech with self-injury from involuntary movement of the jaw and tongue and associated with truncal dystonia along with epilepsy and generalized chorea, with unsteady gait and falls, and impairment of ADL without any perinatal insult or infection. So my localization are basal ganglion is connections, frontal and subcortical circuit, limbic system, and etiology
Your
genetic
patient
like
is having seizure.
cortex.
There
Okay.
is both subcortical as well as subcortical
Got-
involvement.
Yes.
Okay.
Yes, ma'am.
Among the subcortical involvement, we are having, okay, what is that three domains which are mainly involved? Your patient is mainly having a behavioral complaint. Second thing, she is having movement disorder or your extrapyramidal symptoms. The third thing, your patient is having a seizure.
Yes,
Okay.
ma'am.
So that means there is involvement of both a cortical thing as well as subcortical.
Subcortex. Yes, ma'am.
Among the subcortical thing, then you will localize, okay, these are the things where my patient is having deficit.
Okay,
Okay.
ma'am.
And among the history that we have taken till now, we have found one important thing that our patient is having postpartum worsening.
Yes, ma'am.
Okay. So now tell me few things before going ahead. One thing,
So,
what are the choreas or what are the movement disorders which are having predominantly oromandibular involvement?
ma'am, mainly neuroacanthocytosis will have chorioacanthocytosis or macula
The most
syndrome,
common one, most common that you see commonly in your OPD.
tardive
Tardive
dyskinesia.
dyskinesia. Always start with the most common thing. Okay, so the
Yes,
tardive
ma'am.
dyskinesia. So in your history, you have to tell a very clear-cut history regarding drugs. What drugs?
Drugs.
Which drugs?
Ma'am, dopamine antagonist or even some of the anti-epileptic drugs like phenytoin or valproate may cause it, and
What is the most
lithium,
common drug? What is most common drug that you see in your OPD, which your patient comes to tardive
haloperidol,
dyskinesia?
dopamine antagonist, ma'am.
Yes,
Haloperidol,
it's dopamine antagonist. What dopamine antagonist? Common drug,
atypical,
metoclopramide,
metoclopramide.
domperidone. Okay, then it
Mm-hmm.
comes as antipsychotic. Then
Yes,
comes
ma'am.
your anti-seizure medication. Okay. Next,
Yes,
what is
ma'am.
the next cause of oromandibular?
Uh, neuroacanthocytosis, ma'am.
What kind of dystonia you see in neuroencephalitis? What is
Oromandibular
classical
dist,
term?
ma'am.
It's feeding dystonia.
Feeding dystonia.
What is it? What is that feeding dystonia?
Um, they have to put the food on the posterior side of the tongue and then swallow it, because there is the food will come and they have to push the food inside, else it will keep coming out.
The tongue throws out the food as soon as they keep the food inside their mouth. Okay.
Ma'am,
So that's why
sorry.
as soon as the person try to chew the food or they keep the food in their mouth, immediately the tongue throws it out. There's a very severe lingual and the jaw opening dystonia. So that is called as a feeding dystonia. Okay.
Yes.
Other than that, what is common thing? They do have a eyebrow raising. Classical. That's a brow dystonia. They do have recurrent
Hmm.
eyebrows. They raise. Other entities in which will you see oromandibular dystonia?
Wilson's, ma'am.
Okay. And
Others I'm not aware, ma'am.
okay. So other than your tardive dyskinesias and your this neurocancercytosis, there is hepatocerebral, acquired hepatocerebral degeneration, Lesch-Nyhan syndrome, PCAN. They do have a these
Yes,
orofaciolingual
yes,
dystonias.
ma'am. We
Okay.
can be,
And then,
yes, ma'am.
yeah, the Lubec's disease. Again, the D
Hmm.
by T3, Lubec's disease. They also have this oromandibular dystonias or dyskinesias. And among the
Yes,
treatable
ma'am.
disorder, this is a Meek syndrome.
Meek syndrome,
Whenever
yes,
an
ma'am.
old elderly lady coming to you with these jaw opening dystonias or oromandibular dystonias, you always ask them for the breast mass or the ovarian malignancy and we check for this Meek syndrome. Okay.
Yes, ma'am.
Now, your second complaint. So, the what could be differentials?
Um, It could be first we have to rule out the treatable causes. So we'll rule out the autoimmune. One differential is the autoimmune diseases like SLE, Sjogren's, or EPLA. Then genetic cause and other metabolic causes like hyperthyroidism and infections like HIV. Uh, then PML or tuberculum might cause. Then genetic causes like neuroacanthocytosis, NBI, PCAN, or Huntington's, but it is oromandibular dystonia not very common in Huntington's or HDL like, and others like also Wilson's we have to look because of the behavioral as well as chorea dystonia was there, and
And
seizures. Uh,
adult onset MCL, SSP,
yes,
those should
ma'am.
also be kept in consideration. Okay.
Hmm.
So, what are the points favoring neurocancercytosis? What are the points in favor and against?
In points favoring neuroacanthocytosis was mainly it started with oromandibular dystonia, and this severe oromandibular dystonias are seen in this neuroacanthocytosis. Also, along with that, chorea and seizures and behavioral changes are there. And second question, what you asked, ma'am?
Point against?
Uh, Point against. mm,
Why did you keep your
this,
neurocancercytosis above other than other possibilities?
mm, she is young, middle age of presentation is also going, but there is no cognitive impairment. Yeah, later it could be executive dysfunction would be there, but before considering the genetic, we have to rule out the other treatable causes. So
So, your
we
patient is
could.
not having any history of anemia till now. There is no history of any muscle disease. There is no
Uh,
history of any. other cardiac illnesses. So that's why the neurolephantocytosis, although it's a predominantly neurological, but it's usually a multi-systemic disease. So till now, we are
Hmm.
just getting the involvement only in one axis.
Yes, ma'am.
No other axis we have found yet. So that's why we have to see for other causes as well. Okay.
Hmm. Hmm.
So now go ahead with examination.
Uh, she's, ma'am, actually the examination, she has lost follow-up since 1 year. So this examination is
Okay.
1 year back. I had taken
Okay.
the
Sure.
this recent history from a phone.
Okay. No
She
issues.
was conscious, oriented to time, place, and person. Her vitals are pulse was 88 per minute, regular normal volume. RR was 16 per minute, regular. BP was 120, 18, right arm sitting position. No pallor icterus, clubbing cyanosis, lymphadenopathy, or pedal edema. No spine or bony deformity. No skin changes or no cutaneous markers or no KF ring was there. Higher mental at that time was um, grossly normal. Attention was digits forward was 5, back was 3, type A was normal, MMSC was 27, memory, language, speech was all normal. Also, FAB was 18, and there was no parietal or occipital dysfunction. On cranial nerve examination, there was no oculomotor signs, or there was no telangiectasia, there was no KF ring, and even other, there was only oromandibular dystonia, and there was no other cranial nerve abnormality. Motor examination on inspection at rest, she had mandibular dystonia presenting with there was puckering of lips, deviation of jaw to either side. There was flaring of nose and there was facial grimacing. These movements were occurring regularly and uh, they were intermittent and they were pattern movements and they were present at rest as well as when you were speaking, and also along with that there was a little intermittent jerky movement of the tongue which was occurring irregularly, and mm, uh, um, it was also occurring at rest as well as in a movement, and the tone was normal, power was also normal. The reflexes were all all DTRs in all uh, four limbs were 2 plus, and superficial reflexes were present, primitive were absent. And this is her video. This movement was there. This is another video. Your little truncal movement is there.
Okay.
Sensory was intact. There were no cerebral signs at that time, no meningeal signs. On extrapyramidal examination, oromandibular dystonia is described before. Initially, when she came at the first visit, her gait was normal, but then later, her gait was unsteady with a little truncal deviation. So it was not broad based. Her pace was normal, but I feel a little right side bend is there while walking. But this when when she came, the unsteadiness had started a few days ago only.
Okay, wait here. Go back to your first slide of examination. So the patient was conscious and oriented. What did we miss in our patient, and what should be checked in this patient? Did you see for any
Alertness.
systemic examination? What was her cardiac status?
What was her, ma'am?
Cardiac status. Did you do cardiac examination?
No.
That should be done. You are dealing with a patient of chorea. You should always check the patient of cardiac status. Was there any rhythm abnormalities? Your patient is having signs of failure. That should be checked. And the respiratory examination should also be done. For example, you are
Yes.
encountering a patient of your autoimmune disease where the person is having ILD, and you will be getting findings.
Yes, ma'am.
Okay. So the
Yes.
systemic examination is always important. Okay. Now come
Yes.
to the next slide. In higher mental function. So the your patient lost 2 points in attention when you were doing your MMSE. So but the forward digit span was normal. So did you test for other tests also?
Calculation she had lost, ma'am. What did you ask me?
Calculation was, yeah. So more of a calculation was impaired or attention was impaired?
No, ma'am, calculation was impaired. Digit forward
Uh,
was all right,
Digit forward test was valid. A TAPI was also normal,
normal.
but backward digit is impaired. It's 3.
Huh.
And that what was this thing? Your trail B.
Um, at the time I'm trail B, I didn't.
Trail B was not done. Yeah, Dr. Hinal, am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. So that was not done.
No, no, ma'am. Sorry.
Okay, no issue. So actually that should be done whenever you are examining a patient of cognitive dysfunction or the first complaint was only the behavioral issue. The detailed higher mental function has to be done.
Yes, ma'am.
Okay. So
Yes, ma'am.
in your patient already having an impairment in calculation. So can you tell me the localization of a calculation impairment or what is actually the areas that are involved?
Ma'am,
Calculation is
left
not a
parietal.
one low function. See, calculation is never a one low function. It's always told it as, but it's usually whenever you are getting a dysfunction at any lobe, you will get an impairment in the written or the verbal language dysfunction. So we say it is a left parietal, but it's not so. Whenever I'm asking you one question, you have to first comprehend that thing. You should make a letter or the symbol of that thing in your mind, and then it should be go to your parietal lobe for the further processing. So it's not a one lobe function.
Yes, ma'am.
So if your patient is having a problem in calculation in MMSE, so in that case, you should go for a detailed environmental function. It can be at anywhere. So you should check whether her language functions are completely normal or not, whether she can recognize all the symbols or not, and whether she is having problem only in the simple calculation or she is having problem in complex as well. So the detailed things has to be checked.
Yes, ma'am.
Okay. So it's very incomplete for a patient. Come to the next slide. In cranial nerve examination. What was her
Um,
olfaction?
it was normal, ma'am.
Second cranial nerve examination. Where is fundus?
Uh, ma'am, sorry.
Fundus. Is fundus important in this patient or
Huh,
not?
yes, ma'am. Optic atrophy, or sorry, retinopathy also, and optic
Retinitis
atrophy because
pigmentosa, optic atrophy, lot of fundus things are there. So what are the fundus changes in different types of chorea?
um, for ma'am retinopathy, that then um, KF ring, then
Okay, if it is not good. Okay, you first tell
not
me
on
the ophthalmic examination. You tell me the ophthalmic examination in case of a movement disorder. What things will you see?
Uh, and we'll see for pursuit and saccades, square wave jugs, then any telangiectasia is there, or cataract, KF ring, uh, then if there is any pigmentary retinopathy, or
So whenever
optic,
some examiner is asking you this question, you have to be systematic in your answer. Okay. So whenever if
okay.
I am asking you, tell me the importance of ophthalmic examination in movement disorder. Either you come from the inside to outside, but it's very usual practice that you first see the external ophthalmic examination. How are the lids of patient? What is her cornea or conjunctival status? Is there any cutaneous markers over there? Are you getting any telangiectasias? Or is there any changes in iris? Is there any heterochromia or your patient is having your depigmentation or your patient is having coloboma over there? Then you will come on to your anterior chamber abnormality. Do you expect in your patient? Okay. And after that, you will see in your fundus. Then you will come on to the movement, your extraocular movement. Then you will come on to your supranuclear movement. Be systematic.
Yes, ma'am.
Getting my question? So
Yes, ma'am.
you will. So in cornea, you will see for KF ring. Am I experiencing a patient who is having? Okay, I should check for cataract. The Wilson patient have a sunflower cataract. Your other kind of cataract that you can see. Is there any early retinal changes or not? Your patient is having retinitis pigmentosa, or I'm getting a papilledema in my patient, or I'm getting optic atrophy. So primary optic atrophy, secondary optic atrophy. So yeah, ophthalmic examination is very important. You can't skip that in 2 lines.
Yes, ma'am.
Okay. And
Hmm.
after that, you will check for your peri. Then you will come on to your detail. Actually, you should tell it as a clear-cut second cranial nerve examination. You will see whether any perimetry changes are not. There any color vision abnormality you are experiencing in the patient or not. So that should be a detailed thing. It's not shortcut. Not at
Yes,
all.
yes,
Okay, so then you
sir.
will check for extraocular movement. Then the supranuclear movement comes. Then it will come your saccade, pursuit, vergence, your VUR, your OKN. So that should be done.
Yes, ma'am.
Then your fifth cranial nerve, detail fifth cranial nerve, six, seven, eight, nine, like that. You can't skip that.
Yes, ma'am.
Okay. Now come to the next slide. Motor examination. Yes.
Mm. So on inspection, at rest, she was having motor, the oromandibular also I'll describe here, or
So
in the
what is the
extrapyramidal.
definition of chorea?
It is a irregular, bizarre, semi-purposeful, um unpredictable, non-rhythmic, involuntary movement that flows from one body part to another.
Every word in your definition is important. It's an involuntary, irresistible, unpredictable, non-stereotypical, irregular, brief, and abrupt movement, not the jerky one. There's a difference between the word jerky and the abrupt. Okay.
Okay, ma'am.
So if we are saying that our patient is having jerky movement, so probably we want to say that might be our patient is having some sudden dystonia, or you are actually trying to say the patient is jerky, actually having a myoclonus. So the jerky word should not be, it's an abrupt word.
Okay.
Well, better is the bending towards that side or involuntary because the overall thing is there. Then what happens to tone?
Later, it will be hypotonia in Korea. That time it was
Yes.
normal, ma'am.
Initially it was normal. So your patient, you are actually having a patient of 1 year back. Okay. Come to your next slide. Yes. So describe
Marshmallow.
movement of a patient in this.
Sorry. Yes, ma'am.
Describe movement in this. Describe this.
Uh, Ma'am, there is puckering of lips, flaring of nose, and some grimacing movement of face, which is intermittent, and also this jaw deviation to either side. This movement are intermittent and non-rhyth- non-rhythmic, non-jerky, patterned.
Along with
These are
jaw deviation, there is intermittent jaw closure as well. You see, there is teeth grinding intermittently, but your patient is having teeth grinding as well. She is not opening her mouth. Okay,
okay.
and okay, again
Some
play this
facial
video.
grimace. Huh?
Yeah, facial grimacing is also there. Okay, come to the next one.
Here a little movement of the trunk is there, ma'am, upward movement. So
Along
these,
with the face, your patient is having some truncal movement.
mm,
She is having these movements are not rhythmic. Okay, and she is trying to hold her both hands in her hand. Why is that so?
she's, sorry, ma'am, I couldn't hear.
See, again play this video and try to focus on her hand. So actually what happens now, so these Fourier patient, these movements are semi-purposeful. So they try to control these movement of their hands or their limbs. So either they keep their hand on the back side of their hand or they will hold it from the other hand. So they try to stop in that way.
Yes, ma'am.
See the next video of her walking. At that time you will see. In her gait, her stride length is variable. The face is narrow, but the stride length is variable. And she is having swaying to either side,
Yes, ma'am.
mostly towards the left or right, I think. But its stride length is very much variable. She is having intermittently movement of her hands as well,
Ma'am, your
along with the
when
trunk.
while she's walking now, I couldn't actually, I don't know actually what is happening, but your this, she jerked a little in between. So what will
Yes,
we call this? This one, ma'am. It's just irregular. Uh,
it's just an irregular worsening at that time
okay. Okay.
because there was again this truncal swing to the left side, and then her speed suddenly increases. So that's kind of thing.
Yes, ma'am.
Okay. Okay. And the sensory and cerebellar was normal.
Yes, ma'am.
Okay. So come to your final summary and what differentials you will roll out.
Uh, Again, ma'am, first, treatable causes I would like to rule out autoimmune and metabolic. And after ruling out those differential, and then we'll go for the genetic. And also for Wilson's copper, there was no caffeine, but still, urinary copper levels I would like to send, and then genetic testing and MRI brain.
So how will you evaluate this patient? What investigations will you send?
Uh, Well, I'll first we'll send the metabolic parameters like our electrolyte levels and liver function test and thyroid function test. Then her ANA and ANA blood. Then since there was no fever or weight loss, and her WBC was also normal. Mostly there infect and HIV I would like to send uh, for infective. Then MRI brain to see for any choroidal atrophy or
Yes, the
any
first thing
iron
actually
deposition.
that we would like to do is the metabolic thing, and along with that, we will go for neuroimaging. We would like to
Yes, ma'am.
confirm the finding that we are expecting from the history and examination.
Yes, ma'am.
Okay. So, what do you expect in different movement disorders or kind of MRI findings? What would you like to see?
Any caudate or putamen atrophy and iron deposition like in NBI. Uh, then uh, any structural cause if it is there, then uh,
Okay. What are the MRI changes in NBI? What are different type of NBI?
ma'am, PCAN, PLAN, then BPEN, MPEN.
And Copan.
So eye of tiger will see
In what?
that is for PCAN, ma'am.
What is
Eye
that
of
eye of
tiger.
tiger appearance? Why is there
Ma'am,
eye
there
of tiger appearance?
the iron because of the iron deposition, there will be
Hmm.
peripheral T2 hypointensity and central necrosis. So central T2 hyperintensity will be there
In what area?
in the globus pallidus, ma'am.
Yes. And what will you see in plan?
Plan there will be uh, hypointensity in the globus pallidus and cerebellar atrophy may be there and
Okay. What happens in neuroferritinopathy?
what happens in ma'am? What?
Neuroferritinopathy. Again,
Sorry,
there
ma'am,
will be
I
an iron
couldn't.
deposition. No issue. Again, there will be an iron deposition over the putamen in the globus pallidus area. Okay.
Huh.
And what are the MRI changes in Wilson's?
Ma'am, phase of panda sign, there will be T2 hyperintensities in the thalamus also could be there, basal ganglia, and mm, that's it, ma'am.
And you can get a subcortical
Ben,
hyperintensities as well.
huh,
In
yes.
advanced cases, there is subcortical and cortical hyperintensities also. And what are the things in neurocancercytosis?
Uh, Caudate and terminal atrophy will be seen, ma'am.
Caudate and putamen.
Atrophy or T2
Okay.
hyperintensity.
Okay. And what else?
Cerebral atrophy, frontal mode.
Cerebellar atrophy, and along with it, there will be frontal atrophy as well. Okay.
Mm, yes,
So,
ma'am.
okay. And what other workup you would like to send a peripheral smear to look for?
Acanthocytosis, ma'am.
Yes,
In our
we'll look for
patient, there was no
cancer.
acanthocytosis, but
Okay.
the NAMR was normal.
Okay.
And genetic testing was sent, so it came VPS 13A positive.
Okay. Fine. Go ahead. Yeah, please go ahead.
Done, ma'am, only theory part is there. So should I continue?
Yeah, please continue. Finish your slides.
Yes, ma'am. No, so choreacanthocytosis, there is movement disorder, psychiatric plus cognitive decline. Acanthocytosis is seen. There is mutation in the VPS 13A gene affecting lipid metabolism. Age of onset is usually 20 to 30 years and rarely is before 20 or after 50. And symptoms are initially subtle cognitive or psychiatric issues or seizures are there. And then later disorders develop like chorea, dystonia, and even Parkinsonism may be there. Chorea is the hallmark, but it can be absent. Dystonia frequently affects the orofacial muscles with feeding dystonia and tongue protrusion. There is oromandibular dyskinesia. There is tongue and jaw movements are common, resulting in self-injury from involuntary biting, and some may have Parkinsonism. Epilepsy is also a common feature, which could be focal or generalized. Sometimes it could be prominent feature also. In psychiatric and cognitive, uh, prominent is a prominent and early manifestation. Patient could have depression, OCD, impulsivity, even schizophrenia like psychosis. A cognitive decline may have executive function, memory, and attention is impaired. Behavioral disinhibition and personality changes are typical. Gradually progressive disease, even leading to full dependence. Acanthocytosis are seen, but only in 5 to 50%. They also can be positive. In MRI, we see bilateral striatal atrophy, particularly caudate and putamen, and which is not very specific or sensitive. And then we go for genetic testing. And differential are macleoid, pecan, HDL2, or and NBI, Wilson's. Acquired causes we have to rule out like infection, drugs, immunization, etc. Management is basically symptomatic, which includes dopamine antagonist or clozapine. Levodopa can elevate dystonia, botulinum toxin, and DBS of globus pallidus interna, and for epilepsy, valproate and levetiracetam.
Okay. So one, two, three last question, Doctor.
Yes, ma'am.
Just tell me why your patient was having psychiatric manifestations or why she was having frontal manifestation. What circuits were involved?
Basal ganglia connections with frontal prefrontal, that is orbitofrontal, basal ganglia and orbitofrontal circuit, ma'am.
Circuits were involved. So what are the basal ganglia circuits or frontal subcortex, cortical circuits?
Um, Basal ganglia, thalamocortical circuit, basal ganglia oculomotor circuit, and basal ganglia orbitofrontal circuit, uh,
Right.
and this and limbic system.
Okay. And what is the difference between Parkinson predominant diseases and among the patients who are having coriform disorders or your classical Huntington's?
Ma'am, can you repeat the question?
Why your patient is having different manifestations among the patient who are having Huntington's disease versus your patient who are having a Parkinsonian disease?
Huntington's is mainly upper face, ma'am.
No, no. See,
I'm,
I'm asking at the level of
I'm
these circuits. So
circuits.
in
Okay.
patients of so in patient of Huntington's or what these coriform disorders, the patient is having actually the involvement of predominantly caudate nucleus. Okay.
Yes, ma'am.
The caudate is the main part. So because of that, your oculomotor loop is the earliest or the prefrontal loop is the earliest to go. So what happens with the eye signs of what is an earliest eye sign in patients of this Huntington's?
Ma'am, there will be uh, the pursuit will be impaired, and there will be oculomotor apraxia. That is, initiation of the circuit will be slow. Also,
The
the seconds
earliest is
will be slow.
initiation of vertical saccade.
Yes, ma'am.
Okay. So
Uh,
that's why these are predominantly involved in the patient who are having Huntington-like disease. While the patient who are actually having your Parkinsonian disorder, they are mainly having what? The frontal behavioral issues, the limbic system, and along with them, there is a motor loop, which is mainly involved.
yes, ma'am.
Okay. One thing.
Yes.
And okay, fine. This much only. Anything else anyone want to ask? Any questions?
Ma'am, just a description of Korea. If the gait is too much like now, if we'll see her now, then she'll be having generalized chorea. So, well, description of the gait will like how will describe the
So
whole. Uh,
okay, so the gait has to be described. It's the same point. For example, you will say that when the patient is having rising from the chair, she is having some truncal bending, or if, for example, if she is having truncal chorea, then the person is having the truncal swing or the truncal movement at the level of trunk, and because of that, she was bending, or she might fall or may not have her balance as well. So that will actually there is no patient. So current status is what whether she can walk or she can't walk.
she can work, but she was falling.
She was falling only. Otherwise, she can rise from the chair, she can walk.
Huh.
Okay. So, and at the time of a walking, the patient is having a normal, the variable stride length. Her base is narrow. She is swaying to either side. Okay. And along with that, there is a abnormal truncal swing or truncal movement. If there is a limb movement as well, then there is a this flowing, intermittent, or if there's a continuous, then you will see the continuous or what kind of movement is there, which are semi-purposeful movement, which are occurring over her this limbs, her trunk, as well as flowing towards her lower limb. And because of this sudden movement, the patient is having intermittent fall as well. Then we will comment what is that, how is her turning, or whether she can turn by herself or not, or she needs support of one person or two-person, and that much. And then finally, what is her pull test?
Okay, ma'am.
Okay,
Okay, thank you,
so
ma'am.
in that way, you can describe that.
Yes, ma'am.
Okay, any other question from audience?
Yeah, anybody have any question they can ask? Is history, can we use technical term for describe different movement disorder?
Yes, you can use a technical movement, technical terms when you are describing. Yes, you can use that. You cannot say that whether it's a chorea or it's a dystonia. You have to describe in the, see, there is a definition of these terms. So you will not say directly whether this is a chorea or dystonia. You will just say whether these are repetitive or not, jerky movement or involuntary, irresistible. So this definition word has to be used when you are describing a movement disorder. Directly, though, using a word of dystonia or chorea, you cannot use that thing. Anyone else want to ask some question can unmute and ask it.
Okay. If there are no further question, we can conclude that Dr. Hinal has presented the old case because there was no fresh case was available. So maybe she missed some point, but nobody was willing that time. So we have managed like that. So thank you,
Hello.
Dr. Soumya, for moderating this session, and thank you, Hinal, for presenting this case. And thank you,
Thank you,
everyone,
sir.
for attending this session. So thank you.
Thank you so much, sir.
Hello.
Thank you, sir. Thank you, ma'am.
Hello. Hello.
Dr. Asta want to put some final uh, thing.
Uh,
Yeah, go ahead.
Good evening, sir. Good evening, everyone. I'm sorry I couldn't be there for the whole session. Dr. Enel, can you just show the summary slide of the history
Yes,
part?
ma'am. Yes, ma'am.
Okay. Yes. So basically, like, I think it has been discussed in great details with Dr. Soumya. So I would like to just, if something is repeating, just see for that. But I just want to tell you the clinical aspects of whenever you're presenting such cases, long cases. That
Yes,
one
ma'am.
thing is that please avoid using the word psychiatric.
Yes,
Okay.
ma'am. That was a mistake, ma'am. Behavioral, I forgot to
Yes.
change it.
Yes. So everywhere, whether it's the beginning of your presentation, so you have to mention in whatever is happening to the patient, but don't label as anything like psychiatric. Okay. So that is
Yes.
one aspect that you have to remember. Then about the dystonia again, that you have to like the terms that you're using. So first you have to tell without using the technical terms. And then secondly, you
Okay.
have to do a functional classification, a functional summary. So in that, you have to tell that there are certain neuropsychiatric manifestations with oromandibular dystonia, with speech involvement, with followed by feeding dystonia, and so on, with self-mutilation, truncal dystonia, and whatever you have to tell. But in the first part, you have to tell the history summary in as it is, how you will
Okay, so
present in layman terms.
instead of oromandibular dystonia, I'll describe the whole movement again.
No, no, not the whole movement,
Okay.
but you can say some abnormal involuntary movements. And then in your functional
Okay.
summary, then you have to mention that there are neuropsychiatric manifestations with oromandibular dystonia and so on. Then your anatomical localization will be of each. You have to tell that neuropsychiatric manifestations are uh, being localized to here, oromandibular dystonia is being localized to here. So each and every aspect of your thing will have to be clear. Okay, that like you cannot just say that it's basal ganglia, frontal subcortical, and limbic.
Yes.
So that is one
Okay.
aspect. You'll have to localize each and every phenomenology to its own area. And
Yes.
then when you etiology, then you always remember to have a positive and negative points for each one of them. Okay.
Yes, ma'am.
So this is the basic thing. And functional localization, then your anatomical localization, and then your etiology after your summary. So remember for each and every long case that I want to tell.
Yes,
Okay.
ma'am. Yes.
Then can you come to the examination summary? So is it anything different after examination or it's the same?
Same, ma'am.
Same. And so mostly you will not have much difference after the examination, but your history only should be very clear that how you what your case is. But sometimes you can tell some additional points that yes, you found out rigidity, some extra pyramidal features or anything like that that you have to tell, which you have not mentioned. Okay. So like you have written that there is no perinatal insult or infection, but that is only one aspect of the etiology. So as such, you will have to either discuss all the etiologies, no drug exposure and so on. Otherwise, it will not be very because only mentioning about perinatal insult or infection to rule out some etiology will be inadequate. Okay.
Okay,
Then
ma'am.
in your case, you'll also have to mention other systems. Like whenever you're presenting any case, whether it's dementia, Parkinsonism, movement disorder, hypo or hyper, you should always mention other system involvement. For example, with or without cognitive involvement, with or without extrapyramidal features, with or without cerebellar involvement, bowel bladder involvement, sensory involvement, motor involvement, and so on. I understanding for
Yes,
what
ma'am.
all are the major axes of in CNS that all you'll have to mention without any cranial nerve involvement, and so on. You'll have to be very clear. So whatever you have mentioned is you have done a mix of your phenomenology and your etiology. Okay, so it has to be very clear that in your anatomical and functional summary, from your functional summary, it should be very clear that which all systems are involved.
Yes, ma'am.
Okay, so that you
Okay.
should be, or that is what I want to tell.
Okay, ma'am.
Okay, so I think I the lack of time, so we can close here. If you have any questions, then you can ask. But these are the few points that I wanted to emphasize. Okay.
Okay, then we can conclude the session. Thank you everyone for attending. We can
Thank you.
conclude. Okay.